Hello, welcome to the Department of Pediatrics of the Johns Hopkins Children's Center Grand Rounds. Happy to have you join us today. We are going to be starting out with 15 minutes of a COVID update and wanted to thank everybody for all your efforts at this crazy time, really dealing with this COVID pandemic. And we're going to start with Anna Samuels, and then after that we will move into Barry Solomon, who will be talking about social determinants of health in pediatrics. So, Anna.
Hi, hello everyone. Thanks for joining in today at our new routine here. My name is Anna Samuels. I'm one of the doctors with infectious disease and infection control, and it's my pleasure to give you some updates from the past week. So globally, the pandemic continues to evolve, and we have over 700,000 cases spread across the world. In the United States, we're approaching about 150,000 cases. This is kind of a tough graph to read, but the summary is that the trajectories and the rate of growth vary slightly from one place to another, and that is somewhat dependent on testing capacity. And so Iceland in the top blue left corner has the highest testing and also some of the highest density per capita reported. So there is some correlation here with the number of tests available and the number of people actually being detected in those countries. In Maryland, we have roughly 1,400 cases, and the states that saw the first cases, or sorry, the counties that saw the first cases are still those counties with the highest number. And so that pattern continues to evolve proportionally. In Maryland, the overall age distribution of those with a positive test does match other reports from other places in the United States and the world, with the peak really at the middle age. It's a bimodal, or not bimodal, but rather a nice kind of normal distribution here, with the lowest age and highest age groups having the fewest number of cases detected. In our system, this is a similar type of data where it shows the number of positives by age decade. And we can see that we have less than 15 peds up and until last night. They were all in the outpatient setting. As of last night, we do have one positive COVID pediatric inpatient who presented with actually very classic symptoms. And there's also one patient at Mercy as well. And I'm getting information as we're talking here. And a baby at Sibley is reported this morning. The green in these bars are all outpatients, while the other colors represent other hospitalized patients in the various institutions here. The majority of patients are in the adult age category. As of last evening, we had a total of 57 hospitalized at Johns Hopkins Hospital, and 20 adults were on ventilators. These are dynamic numbers, so they may have even been different as of this morning. Overall, the message that we shared last week, I think, is still true, that the risk of COVID to our pediatric healthcare workers still remains greater acquisition from our adult colleagues rather than necessarily our pediatric patients that we're caring for, though that risk still exists and appropriate PPE is warranted. The testing availability is impacting our understanding of the prevalence. And as I suggested when I was pointing out the Iceland numbers on the earlier graph, in this graph, we have Iceland and the Netherlands with the distribution of positive COVID cases by age group. And what we can see is that in Iceland, where there is a lot of testing available, it is that very nice normal distribution. Whereas in Netherlands, where more symptomatic patients are being tested, they have more positives in the higher age group. So this is reflecting likely the disease severity rather than the true disease prevalence across all the age groups. I'd like to share some specific updates. I know folks are tuning in from across the state. However, these are some of our local updates. One of the things that we've changed this past week is the actual testing. So last week at this time, we were doing a rapid influenza RSV plus COVID all in one swab. Influenza has rapidly decreased over the past 2 weeks, and the supplies for the rapid test are also diminishing. And so we have now moved to ordering a COVID-only test alone, and we still have the RVP for those special populations where knowing other viral processes is important, such as the oncology or some ICU patients. This week, one of our evolutions is a new rapid Cepheid test. It takes roughly up to 1 hour, and this will be available and prioritized for the patients whose bed management is most impacted. For example, people who are in the ICU or those who must be admitted if they're COVID positive because they can't return from wherever they came from. We also have updated our testing algorithms to reflect those changes. So this is actually a whole page of an algorithm summarized in one slide, but just to point out some of it out loud. If a patient has respiratory failure not explained by an alternative diagnosis, such as a toxin ingestion, for example, they would get testing if they have 2 of any of the following symptoms: fever, sore throat, cough, new shortness of breath, myalgias. If they have 1 of those symptoms and a known positive confirmed exposure, or one of the new things that has come up this week is a new acute loss of taste or new acute loss of smell not otherwise explained, as there is some growing anecdotal evidence, particularly in the otolaryngology community, of this being an isolated separate symptom. And so this is being incorporated into our testing algorithms, trying to keep up with that rapidly evolving information. Patient populations prioritized for testing will include immunocompromised patients, those who are pregnant, and in some cases, those with significant underlying comorbidities. However, for the general pediatric patient without any underlying issues, we are not currently supporting testing right now and are trying to maintain supplies for those patients who are coming into the hospital setting. There have been a lot of questions about PPE and masking and the role of masking in different settings or for different types of people as healthcare workers. At this moment in time, as an institution, we're not in the position to support universal masking for all of our staff. And this would jeopardize our ability to maintain supplies for those with known COVID or the highest risk encounters. The institution is working towards securing additional masks and novel production of masks to funnel in additional supplies. We still support droplet PPE if a patient warrants droplet precautions, but is COVID negative or not under investigation. If there's concerns for possible secretion splashes, in line with standard precautions, it would be important to also use mask and eye protection. There are some high-risk procedures that have been identified and will universally use airborne contact plus eye protection, such as rapid responses, for example. And then a clarification point, because I think, as many people are learning about all the different types of PPE available, just to make a distinction, these 3 types are considered equivalent. So an N95 with a face shield, a PAP or Draeger respirator with a face shield are considered equivalent in terms of their protective ability for the staff. We have a lot of new materials and guiding documents available on our website now. So there's PPE clarifications and guidance, there's new discharge and transfer guidance, there's emergency room frequently asked questions for the workflow of the emergency room. There's a nice handout on which disinfection products are appropriate for COVID. There's additional occupational health information, and coming actually maybe as of last night, but at least today, we'll have some specific breastfeeding guidance, and I'll talk a little bit more about this in a minute. And so kind of moving on, I want to credit some of my colleagues, Sean Ralston, Julia Johnson, and Rebecca Same, who helped support put some of these slides together. But I wanted to share some of the newest information focusing on articles presented over the past week that are impacting some of our decision points for our patients. So there is an article in the American Journal of Obstetrics and Gynecology. This was a case series of 7 women who delivered in New York. 2 of those patients were asymptomatic at the time of delivery. However, postpartum developed symptoms and tested positive for COVID. So at this time, our deliveries are going to occur with airborne PPE, and women will be tested if they develop symptoms, but we are not currently testing asymptomatic individuals. This is a high priority group. When I mentioned the Cepheid test, this will be a high priority group to have the most rapid turnaround time, so we don't unnecessarily have to separate babies from moms if it's not necessary. Some other articles about neonates, and the next series that I'm going to talk about really are getting at this question of, is there vertical transmission of the COVID virus to the fetus? In this article, they looked at 33 neonates born to mothers with known COVID infection. All the babies were born by a C-section and separated immediately. 3 of those 33 babies were positive by PCR on day of life 2 and 4, and then cleared by 1 week. 2 were term, 1 was preterm. Their symptoms included fever, lethargy, pneumonia. None needed ventilation, and there were no deaths. They did have elevated inflammatory markers, lymphopenia, and abnormalities on chest X-ray. However, 2 of them did have potential alternative diagnoses such as meconium or Enterobacter sepsis, and it's also unclear if there were other potential exposures that could have led to a positive test in the baby at day of life 2. Another article, and these are all from JAMA or JAMA Peds. This is about possible vertical transmission from an infected mother to her newborn. Now the question has become, what is the role of serology or antibody testing in the newborn? So in this one baby, a neonate was born at 34 weeks to a mom with known COVID. The mom had elevated IgM and IgG. The infant was again born by C-section, negative pressure, and they were separated. At 2 hours of life, the baby's IgG was elevated and the IgM was elevated. And so this raised the question of, does that IgM reflect an in utero transmission and antibody response in the fetus? All of the COVID PCR tests from that baby were negative from day of life 0 through roughly 2 weeks of age. This was followed with another article looking at 6 mothers with COVID. All the babies from these mothers were asymptomatic, and they all also had negative COVID PCRs. In 2 of those 6 babies, the IgM was elevated, including the IgG, which could be transferred through the placenta. So Dr. Kimberlin and colleagues did release an editorial in response to this article in particular. They noted some issues that IgM can cross-react, and so it's not clear based on these 2 or rather cumulatively 3 instances what we should deduce from this. They also noted that a rapid decline in IgM might be unusual if there was a true infection triggering that IgM response. And so ultimately at this time, it's inadequate to really understand what those assays, the sensitivity of those assays and how we can interpret them. So in summary, it seems to be that at this moment in time, it's inconclusive whether there is in utero transmission of the virus. There is a potential of stress on the fetus due to the maternal infection, and there's also a question of potential exposures after delivery to the infant as well. So still some questions here, and I don't think data will continue to come as case series and larger studies become available, but we just don't know yet. In terms of how we're going to approach this, at this moment in time, we will separate infants born to mothers with known COVID infection, and we will be testing those babies for COVID after the first day of life. And similarly with breastfeeding, breast milk, there has not been virus detected in breast milk. Breastfeeding is generally supported by the large groups such as CDC, WHO, and we are not calling it a contraindication to provide breast milk. If the mother and the baby do have to be temporarily separated, the mother can express breast milk and that can be given to the baby. Just moving on, and I'm going to wrap up after this, is some treatment that we know. There are some antiviral treatments being explored right now. One of those is remdesivir. A randomized control trial in adults is ongoing, and children can receive it by compassionate use. Hydroxychloroquine may be getting the most press right now because there was this non-randomized study that seemed to show increased virologic cure in 20 of 36 adults, some of which also got azithromycin. There's a notable risk of hydroxychloroquine with QTc prolongation and serious arrhythmias, and that's potentiated with addition of azithromycin. So there's some notable risk factors here for hydroxychloroquine. Leponavir, ritonavir is another drug being looked into. There's an open label randomized trial that was done among 199 hospitalized adults. There was overall no difference. However, in a subgroup of those adults, less than if those who received the medication early in the course did seem to have a faster recovery. So there's more to learn here. The drug is poorly tolerated and there's many drug interactions. So in treatment summary, at this time point, there's no FDA-approved therapies for this virus. The studies are ongoing. None have been shown to be clearly effective, and there are certainly adverse effects to consider. Supportive care is recommended for children. Antiretrovirals are not recommended right now for mild disease in the outpatient pediatric population. And if a patient is admitted with a more significant infection, ID will be consulted and we can explore the role of antivirals for that individual patient. There's a lot of additional resources. So thank you so much for tuning in again. We'll continue to try to update you, and I will pass along to Dr. Solomon now.
So I wanted to really thank Anna Samuels and also Erin Millstone, who are really experts in infection control and have really helped us here at the Children's Center through this pandemic. They have been really outstanding, and we are so lucky to have their expertise. Wanted to share that we have at the Johns Hopkins Pediatrics, we have a COVID Incident Command Center that's open daily. I know you may have lots of more questions even after listening to Anna's update, and we are open to answering your questions at the phone number listed as well as in the email below. So please continue to share with us. And you know, we have developed many algorithms, as Anna mentioned, for the babies that are born to moms that are COVID positive or under investigation, for ambulatory clinics, for the emergency department. And in a spirit of sharing, we are happy to share with you. Just recognize that things are rapidly changing, so we have updated these algorithms many times, and it really should depend on your local epidemiology, your local supply of and availability of testing as well. As I mentioned last week, we have a regional pediatric inpatient hospital email group that has been sharing information. Again, I think that this sharing of information across hospitals, across practices is really helpful for all of us to get through this pandemic and provide the best possible care to our patients. If there are any admissions, we are open here at Johns Hopkins for COVID or non-COVID admissions, and those phone numbers are listed. And there are lots of COVID resources out there, and in particular, we have developed talking points for pediatric clinicians and a community resource listing for the Baltimore region of community resources. For instance, how does one get their WIC in this environment when the WIC offices are closed, and are happy to share those if you want to email Sherry Crawford, and we are happy to share those resources. So thanks for everyone's effort in really trying to address this pandemic with the best possible care for our patients. Shifting today, but I feel like it's not really a shift, to the topic of grand rounds today, which is on social determinants. And I think the issue of addressing social determinants is possibly even more important now than ever. Oh, I have to tell you about future grand rounds. You are welcome to join us for future grand rounds. Next week, we will have, again, Dr. Samuels giving us an update. And we have Dr. Ling He also giving grand rounds on mitochondrial dynamics. The following week, we have another COVID update and some scientific abstracts that we will be presenting, but we welcome you to join us by Zoom in the future times as well. So on to our grand rounds topic for today of addressing social determinants. I think in this time of stress and amid COVID, this is probably even more important than ever. And I think that we have the best possible speaker with Barry Solomon speaking today on this topic. As you may know, he is Professor of Pediatrics at Johns Hopkins. He is the Division Director of General Pediatrics and Adolescent Medicine here. He's also the Assistant Dean for Medical Student Affairs, so wears a lot of hats. He's a graduate of the University of Pennsylvania School of Medicine, completed residency at Children's Hospital of Pittsburgh, and then we lured him here to be a fellow in general academic pediatrics and have not allowed him to leave ever since. He also has a master's in public health from the Bloomberg School of Public Health. His clinical work, research, and teaching and advocacy really have centered around addressing the social and behavioral health needs of urban youth and caregivers through educational curricula and clinic-based interventions. He has been the Harriet Lane Medical Director for 14 years, where he really has developed the Harriet Lane Clinic as a center for wraparound services and also for teaching our next generation. His mission has really been to provide quality family-centered primary care for patients and for pediatrics, children and families, training the next generation of child health professionals, as well as advocacy for vulnerable populations. And I think that he will be teaching us a lot today about social determinants and how we need to really be integrating this in the care that we provide. So thank you, Barrett.
Hi, everybody. Can't see myself, but hopefully you can see me if you'd like. I'm just gonna wipe down the keyboard really fast. Thanks again. I don't know if this is an approved cleaning device. So here are our objectives. By the end of the talk, I hope that everyone who's listening will be able to explain the historical context of addressing social determinants of health, which I'll refer to as SDOH, recognize the role healthcare professionals play in addressing SDOH, understand current evidence and research gaps in integrating SDOH into pediatric care, and then describe some of the models that I'll share with you for addressing SDOH here at Hopkins. So just to start off with some background, as we know, health disparities is defined as differences in the incidence and prevalence of health conditions and health status between groups. These groups could be based on socioeconomic status, race, ethnicity, sexual orientation, gender, disability, or geographic location among them. We also know from research that worse health is associated with lower access to the social determinants that support health. These are things like healthy food, safe housing, education, safe neighborhoods, freedom from racism and discrimination, again, just to name a few. Health disparities are referred to as health inequities when they're the result of the systematic and unjust distribution of these critical conditions. Paula Braveman at UCSF defined health equity as when individuals attain their full health potential and not be disadvantaged from achieving this potential because of their social position or other socially determined circumstance. This is a figure you may have seen before from the Robert Wood Johnson Foundation that shows the difference between equality and equity. We know that one size does not fit all. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. And as the slide states, that requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. In 2003, the CDC conducted a forum on social determinants of health disparities. Participants included representatives from community organizations, academic settings, and public health practice. In 2008, they published this workbook to encourage and support the development of new initiatives and expand existing programs and partnerships to address the social determinants of health inequities. It includes tools and information from efforts to develop, implement, and evaluate interventions that address these social determinants. This same year, the WHO published this report from the Commission on Social Determinants of Health to organize evidence on what can be done to promote health equity. In the introduction of the report, the authors state that social justice is a matter of life and death. It affects the way people live, their consequent chance of illness, and their risk of premature death. These inequities in health, avoidable health inequities, arise because of the circumstances in which people grow, live, work, and age, and the systems put in place to deal with illness. The conditions in which people live and die are in turn shaped by political, social, and economic forces. Hopefully this will work. This is a 4-minute video that was produced by the Agency for Clinical Innovation for North Shore Wales in Australia. Using animation, I think it does a great job capturing what we mean by SDOH and the impact that it plays on our patients' lives. Hopefully the audio will come through as well.
Even before we're born, there are factors at play which influence our health and well-being. The conditions in which we're born, grow and live can affect us and our health in different ways. We also react to them in different ways. Poverty, stress, lack of adequate housing, education, unemployment and poor access to transport and nutritious food are some of the things that can affect our health and life expectancy. The World Health Organization recognizes that health and well-being are strongly influenced by social, economic, and environmental factors known as the social determinants of health. The environments in which we are born, grow, live, work, and age can have stronger influences on our health than our genetic family history or behavioral risk factors. A person's social and economic circumstances affect their health throughout their life. The relationship between income and health is on a gradient. This social gradient means that even a little bit of wealth can increase your likelihood of being healthier. A stable source of healthy food, appropriate, affordable and secure housing, education and employment, relief from financial distress, access to transport and services, loving and stable relationships, and being able to make choices about our lives means we are less likely to experience chronic conditions such as diabetes, cardiovascular disease, depression, anxiety, and other mental illness. How we are treated by and interact with others also has a huge impact. Stressful circumstances over a long time that make people feel anxious or unable to cope, discrimination, racism, social isolation, or just being treated as less than equal can lead to poor health. And the interplay between these factors and a person's socio-economic circumstances can compound the situation. Experiencing a lot of stress and feeling unable to change things can also lead to poor health. But as health clinicians, there are things that we can do to make a difference. Look beyond the illness to see the whole person and try to understand the reality of their daily situation. Ask them what they think would make a difference to their lives and really listen. It may be that taking care of their health in the way you suggest won't be easy. It may make things more stressful for them. So try and see what other support you can offer. Advocate with them and give them knowledge on where to turn for help. Offer transport options for people to come to your service. Consider food vouchers to families who are struggling, or talking to nutritionists who can work with people to cook a healthy meal on limited income. Offer education about making better lifestyle choices to encourage healthy eating. But remember that all the advice on good nutrition will be a challenge if people are living on a limited budget. Offer medications for longer periods of time for people who can't get to a pharmacy easily, and refer people to other services like counselling or housing assistance. Help improve their health literacy by encouraging and working with them to better understand their illness and be more active in their own health care. Even one small action, like really listening and being compassionate, can go a long way to improving their health. Changing your practice, even ever so slightly, might mean the world of difference to someone.
The Robert Wood Johnson Foundation has been a key driver in funding SDOH efforts, leading policy changes and developing professionals with the skills to tackle this issue. In 2009, RWJF convened the Commission to Build a Healthier America, highlighting the impact of early life experiences, education, income, employment, housing, community connections, race and ethnicity, and the economy in general. Around this time, the lay press began covering SDOH, as you can see here in this article in the Huffington Post. As we know, social circumstances, environmental exposure, and behavior are estimated to account for 60% of the risk of premature death. In 2011, Robert Wood Johnson Foundation published Healthcare's Blind Side based on a survey of 1,000 US physicians using the American Medical Association master file. This summary reviews key findings from an online survey of the 1,000 physicians. 690 were adult primary care physicians and 310 were pediatric providers. Input was provided by Health Leads, an organization that has been at the forefront of SDOH, and I'll be telling you more about that later in the talk. As we can see here, 80% of physicians felt that patients' social needs are just as important to address as their medical conditions, and unmet needs are directly leading to worse health outcomes. They also felt that they're not confident to address these. 75% wish the health system would pay for costs associated with addressing their patients' social needs. These needs include nutritious food, transportation assistance, and adequate housing. The key takeaway messages from this report are shown here. First, the healthcare system needs to recognize that social needs are connected to health. Second, physicians and healthcare teams need to be equipped with the resources to keep and make patients healthy. And finally, we need to rethink and redesign how the healthcare system can address patients' unmet social needs. In 2012, in his presidential address for the Academic Pediatric Association, Dr. Bernard Dreyer announced the formation of the APA Task Force on Childhood Poverty. Some of us in general pediatrics and adolescent medicine were lucky enough to participate on this task force. Just a few years later, Dr. Dreyer became president of the American Academy of Pediatrics and put child poverty on the national stage. In 2016, the AAP published this policy statement, which says, because pediatricians work to prevent childhood diseases during health supervision visits and with anticipatory guidance, the early detection and management of poverty-related disorders is an important and emerging component of pediatric scope of practice. The statement also recommended we screen for risk factors within social determinants of health during patient encounters and refer those that are positive to resources. And we also advocate for public policies, including initiatives that increase access to healthcare, healthy food, and safe and affordable housing. More recently, an ad hoc committee of the National Academies of Sciences, Engineering, and Medicine examined the potential for integrating services addressing social needs and the social determinants of health into the delivery of healthcare. In this report, the committee made recommendations that we should, 1, be aware of the importance of SDOH, 2, offer assistance and make adjustments for patients with social needs, and 3, align ourselves with communities and advocate for policy change. The report talks about the need to expand social needs care services, better coordinate roles for social needs care providers in interprofessional care teams across the continuum of clinical and community health settings, and lastly, optimize the effectiveness of social services to improve health and healthcare. We can see here in this figure from the report the 5 A's that are depicted, which shows adjustment and assistance are at the individual level, and alignment and advocacy are focused on communities. Awareness pertains to both individuals and communities. This is a slide from the report that was included in a presentation by Dr. Laura Gottlieb, one of the report contributors, who is a family medicine researcher at UCSF and director of the Social Interventions Research and Evaluation Network, or SIREN. I'll speak more about SIREN later in the talk. This table shows how the 5 A's can apply to a patient and the community. We can see that healthcare teams could work more systematically in asking all or targeted groups of patients, like those with diabetes in this example, about food insecurity. At the individual level, providers could adjust medication choices or doses based on social risk factors. For instance, they might change insulin doses for patients on food stamps so that when food benefits run out at the end of the month, there's a lower likelihood of hypoglycemia-related hospitalizations. They might connect patients with food insecurity to food assistance programs. And at the community level, health systems could be better collaborators and partners for community-level food programs. Hospitals could invest in locally sourced food and invest in local food banks. And more generally, health systems could advocate for policy changes like healthier and more generous food benefit packages to improve food resources. At the practice level in 2014, Tina and I shared the Harriet Lane Clinic model for addressing SDOH using a life course theory approach. Life course theory looks at how chronological age, relationships, common life transitions, life events, social change, and human agency shape people's lives from birth to death. As many of you know, the HLC is a pediatric and adolescent medical home that cares for a large population of families who live in our local community. Many face significant health and healthcare disparities, much of which is influenced by root causes of living in poverty and intergenerational transmission of racism and trauma. The programs on the outside represent core services offered through the clinic to meet our families' needs. Later in this talk, I'll share some of our work and progress to date on 2 of the programs related to health leads and financial futures for families. About 6 years ago, then medical student Aditi Vasan, pictured here at the bottom, worked with me on her scholarly concentrations project to look at the use of our co-located services in Harriet Lane and the association with healthcare utilization. In this study, Aditi conducted 80 face-to-face interviews in the clinic. Parents reported their knowledge of, use, and satisfaction with 12 of our on-site services at the time. They also reported their satisfaction with the clinic and perception of the clinic as a medical home. Aditi also looked at associations between use of services and healthcare utilization. Just to mention, Aditi is now a pediatric hospitalist at CHOP and a fellow in the Robert Wood Johnson National Clinician Scholars Program. In this study, we found that parents knew about a mean of 6 of the 12 services. 90% had used 1 or more services and 42% had used 3 or more. The highest used are shown here, including the Safety Center, Health Leads, and our Maternal Mental Health Program. In our bivariate analysis, 3 or more services was associated with greater missed well child visits, likely representing a higher need and more stressed group of parents. In our multivariable analysis, no differences were found. On the right, you can see in both the lower and higher use groups, we hit a ceiling effect for caregiver satisfaction and the perception of the clinic as a medical home. However, both were statistically significant. As most of you know, on our Bayview campus since 2013, Centro Sol has served as the bedrock for the Latino community through the provision of clinical care at the children's medical practice, conducting research, community outreach and education, and advocacy. Much of their work centers on addressing SDOH. Sarah Polk, Kathleen Page, Monica Guerrero Vasquez, and other team members often take their clinical experiences to the national forefront to advocate for the Latino population in the US. In fact, they just published a perspectives piece in the New England Journal this past Friday, shown here at the bottom, on the negative impact of White House policies on this community during the current COVID crisis. Let's move on to look at the published literature in SDOH and pediatrics. In 2018, Andy Beck from Cincinnati Children's led an all-star group of researchers to explore peer-reviewed articles published between 2000 and 2017. In this paper, they provide this conceptual framework that shows how positive and negative social and environmental exposures, structural, economic, and political factors can be traced to health outcomes for individuals, households, and populations. Many people talk about SDOH getting under the skin like adverse childhood experiences. As we know, there's data showing socially disadvantaged children have more insulin resistance, pro-inflammatory mRNA expression patterns, chronic cortisol elevation, and shorter telomere length, which is a marker of premature aging and disease prediction. These physiologic changes interact with health-related behaviors to impact both short and long-term health outcomes. In the second figure in the article, they show how interventions targeting structural and social determinants can be either at the individual patient, household, or community levels. For example, at the individual level, a clinic may have a health insurance navigator. At the household level, a community help desk might be implemented, like Health Leads, to provide and connect families to employment or other resources. And at the community level, groups may participate in advocacy efforts to inform or change policy. This group of researchers found 13 total pediatric targeted studies, which they classified as moderate or high quality. 10 studies involved interventions targeting a specific health condition, and 3 reported on intervention screening and providing assistance with multiple social needs in the same encounter. As we can see, some involved community health workers helping those with asthma, others focused on child development, and some on child maltreatment. SEEK is a program that was developed by Howard Dubowitz at the University of Maryland that trains providers to screen for and help connect patients with services to address risk factors for child maltreatment. Bob Seege created the DOLCE program, which stands for Developmental Understanding and Legal Collaboration for Everyone, and it's based on the Healthy Steps and medical legal partnership models. Family specialists conduct needs assessments and work directly with families to provide connections to resources. In our RCT, the program showed increased access to food, benefits, and utilities, and increased immunization and preventive care visits, as well as decreased ED visits. Laura Gottlieb used volunteer patient navigators to administer a 14-item social and mental health needs screening instrument to caregivers. They then provided either in-person assistance or navigation, accessing these services with follow-up telephone calls, or written information on relevant community resources, which was the active control group. In her randomized trial with 1,800 families, they showed decreased social needs and improved reported child health in those receiving the in-person navigation. The final model in the paper was Arvind Garg's We Care research. Arvind, pictured here at the bottom, was a general academic pediatrics fellow here at Hopkins. He completed his training in 2008, and I should make a disclaimer that he's one of my closest friends. For his fellowship project, under the mentorship of Jan Serwin and Arlene Butts, Arvind conducted a randomized controlled trial of a 10-item self-report psychosocial screening instrument in the Harriet Lane Clinic. Pediatric residents and parents were randomly assigned to either the intervention or control group. During a 12-week period, parents of children aged 2 months to 10 years presenting for a well child visit were enrolled in the study. The intervention components included provider training for the residents, administration of the screening tool before the visit, and provider access to a community resource book. Parent outcomes were obtained from post-visit and 1-month interviews and from the medical record. Provider outcomes were obtained from a self-administered questionnaire after the study. This is the front page of the original We Care survey. The full survey asks families whether they have needs for education, employment, help with smoking cessation, drug or alcohol use, homelessness, IPV, or intimate partner violence, and childcare. And if they respond yes, the follow-up question is whether they would like help with these needs. Residents in the intervention group reviewed the screener and had access to the resource book to provide a 1-page resource referral. He enrolled 200 parents, 100 per group. The majority were African-American mothers who were high school graduates. About 20% received temporary cash assistance, or TCA. About half received food stamps, and roughly 40% were enrolled in the WIC program. In this table, in the adjusted odds ratio column to the far right, based on the post-visit interview across all social need domains, a higher proportion of parents reported discussing with the resident compared to those in the control group. Arvind also found that intervention group parents received a greater number of referrals. In his survey of residents, none of the residents in the intervention group reported feeling uncomfortable discussing findings from the survey, and none felt that the intervention slowed down the visit. In 2008, Arvind moved to Boston, first to Tufts and then to Boston Medical Center, where he's been conducting research on a larger scale, including an NIH-funded randomized controlled trial that was conducted at 8 urban community health centers in the Boston area. He recruited mothers of healthy infants. In the 4 We Care clinics, mothers completed a self-report screening instrument, and providers made referrals for families. Research staff followed up by phone. Families at the 4 control community health centers received usual care. In this study, 336 mothers were enrolled, 168 per arm. The table on the top of the slide here shows that there were no differences in basic social needs between the groups with the highest needs, between the 2 groups, with the highest needs being employment and housing. In the bottom table, we can see 70% of the We Care mothers received 1 or more referrals at the visit, compared to 8% in the control group. At the 12-month follow-up, more We Care mothers had enrolled in a new community resource. You can see here that's 39% versus 24%. And We Care mothers had a greater odds of being employed, and their children had greater odds of being in childcare. Arvind has continued this line of work and has become a leading national expert and mentor for trainees interested in SDOH research. He's currently funded by NICHD to conduct a We Care study in 12 of the pediatric research office settings for PROS practices using a wedge cluster randomized controlled trial. His study aims to teach practices to identify local resources and develop resource referral information on 6 social needs, as well as screen for unmet social needs and make referrals. I do hear someone in the audience on the computer, so if you can mute yourselves, that would be great. Keith's gonna help me mute everybody. Sorry. I know, it's kind of cool. Mute off. Thanks, Keith. Awesome. Oh, here we go. Okay. So while much of the work has been done in the ambulatory setting, there have also been studies and programs built on SDOH in the inpatient settings and the emergency department. So Jeffrey Colvin, who is at Children's Hospital Mercy in Kansas City, conducted a study on their general pediatrics inpatient resident team. He used the iHelp tool, which stands for Income, Housing, Education, Legal Literacy, and Personal Safety. Compared to those in a control group, residents who received iHelp training documented more social needs screening in their admission notes, and they were also more likely to place social work consults. Jeffrey also showed that parents report favorable opinions of being screened in the inpatient setting, and they felt that they could ask their physicians for help. Earlier, I mentioned Siren, whose mission is to improve health and health equity by advancing health quality research on healthcare sector strategies to improve social conditions. Siren was founded by Dr. Laura Gottlieb again at UCSF, and Caroline Fichtenberg, who used to work as the Director of Epidemiology here in the Baltimore City Health Department, who worked with some of us here at Hopkins, is the Managing Director of Siren. In a recent special issue in the American Journal of Preventive Medicine, Caroline was joined by Kamala Mistry, who is the Associate Director in the Office of Extramural Research, Education, and Priority Populations for AHRQ, and a faculty member and research mentor to many of our fellows in general pediatrics, as well as Dawn Alley, who is Deputy Senior Advisor for Value-Based Transformation for Health in Health and Human Services. And they authored this article using the concepts from the National Academy's paper I showed you before, and looking at the individual level A's, that's assistance and adjustment. This model shows how the identification of social needs can lead to receipt of social services with potential for a decrease in stress, which helps to drive improvements in health outcomes and improved cost utilization. In the orange box at the bottom, they also suggest that these social interventions might reduce provider burnout, which could also reduce costs with less provider turnover. In the paper, Caroline, Kamala, and Dawn share what is known about social needs screening. Specifically, there is high acceptability overall, though a few pediatric studies have reported some concerns with study participants. Patients and caregivers appreciate being asked, even if they don't receive assistance at the moment. And compared to being asked questions by a clinical provider or staff member, self-administered screening increases disclosure. They pose interesting questions for us to consider, like what screening approaches maximize patient acceptability? Should social needs screening be standardized? And is screening really needed, or should everybody just be offered assistance? Studies have shown that provider and staff training and technology can increase screening rates, but practice settings do need a fair amount of support to implement screening. As far as intervention effectiveness, we saw in Andy Beck's paper, the literature is sparse. More research is needed to understand if interventions work, and if so, through what mechanism. Are they cost effective, and if so, for whom? What are the unintended consequences for patients, care teams, and community-based organizations? For example, if a CBO doesn't have the capacity to meet the needs of clinics who began screening, then that would be troubling for their organization. Also, how can patient engagement and participation be maximized? What payment and quality incentives drive screening adoption? And finally, and most importantly, what is the impact of these interventions on health equity? For the rest of the talk, we'll focus on my third objective, sharing some of the SDOH work that has occurred here in pediatrics over the past 10 to 15 years. Fortunately, soon after Arvin conducted his We Care study in the Harriet Lane Clinic, we were approached by Health Leads, which was then Project Health, based at Boston Medical Center, to be the 6th partner city to implement the program. We did this in collaboration with Hopkins undergraduate campus, and the Harriet Lane Clinic served as our first site. We used Arvin's findings as our needs assessment, recognizing our patients' highest needs related to education, employment, homelessness, and food insecurity, as well as childcare. At the time, Arvin and I worked closely with the founding executive director for Health Leads Baltimore, Mark Marino, pictured here, as well as Sonia Sarkar, who was an undergraduate who was in our first cohort of students working in the Harriet Lane Clinic at the desk. Mark left Baltimore to work for Health Leads National Office in Boston, then moved to become the Chief Development Officer for Seed Global Fund, and then spent some time as Vice President of Business Development for Planned Parenthood. Right after graduation, Sonia moved to Boston to work at Health Leads National as the Chief of Staff to the founder, Rebecca Oni. And later she returned to Baltimore to serve as Chief Policy and Engagement Officer at the Baltimore City Health Department. She currently is in the Doctorate of Public Health degree here in the Bloomberg School of Public Health, and a Robert Wood Johnson Foundation Culture of Health leader. Sonia is actively working on her dissertation entitled Assessing the Impact of a National Health System Network on Local Investments to Address Social and Economic Determinants of Health. As you can see, both of these individuals are changing how we address social determinants on a larger scale. Health Leads is run by a program manager, Kristen Topel, who has served in this role for the past 5 years and oversees all 3 desks that you will hear about shortly. Each desk either has a program coordinator or a program navigator to manage the day-to-day operations. Currently, those individuals are Sarah Hill, Nick Machado, and Ashley Skipper. After screening is conducted, as you can see here in the figure on the left, undergraduate student advocates receive clients at the desk or come into the exam room. They conduct an in-depth intake, link families to resources, and then provide close follow-up by phone. They also send feedback to the referring providers through Epic. There are other student leadership roles, and all students receive intensive training. Again, the figure on the left shows the process from screening to closing the loop with the providers. As many of you know, this was the social needs screener we've used in the Harriet Lane for a number of years. Again, this was based on Arvind's We Care survey, though we removed the step of asking if families have these needs and asked directly if they would like help with them. Our providers also know that this screener is in Epic in the Pediatrics Additional Social History section, and a few years back, we incorporated a referral to health leads through Epic. In our first 5 years, Arvind and I conducted 2 small studies to look at what we called at the time the Family Resource Desk through health leads. On the left, we can see that in 2007, during the initial 6-week pilot, only 6% of families accessed the desk. At the time, we didn't have a full complement of students to staff the desk, so it was somewhat spotty. The most common identified needs were childcare, employment, housing, and food. In this pilot, only 64% were contacted and 32% of families enrolled in services. Then a little bit later, between 2008 and 2011, we did another study and found similar needs in a larger population. The mean number of needs was 2 per family, and the program found higher resource enrollment at 50%, with 85% of referred providers receiving an update from the advocates. In 2016, David Jagannath, pictured here at the top, who was a Hopkins pediatric resident at the time, now a PEDS ID fellow at Stanford, and Carl Johnson, pictured on the bottom, who was a freshman and one of our health leads desk advocates, who's now in a PhD program at UNC, worked with me to look at how we might expand the scope of services of health leads to provide additional support for families with financial insecurity and employment needs. With many undergraduate and graduate research assistants, we conducted a survey of 221 caregivers and adolescent patients in the Harriet Lane Clinic who presented for well or acute care visits. We gathered data on demographics and financial status. We asked them about their knowledge of the Earned Income Tax Credit, or EITC, and the Child Tax Credit. We assessed financial self-efficacy and literacy using validated scales, and we asked if the clinic should provide on-site financial assistance programs. The sample included mostly African-American female respondents, many of whom were parents themselves. We also conducted a separate study doing 18 qualitative interviews, specifically asking about their perceptions on whether or not there were benefits or challenges of integrating financial services into the medical home. In the first study, we found that 36% of respondents did not have any household earned income. Just over a quarter had a household earned income of less than $12,000 per year, which is considered extreme poverty for a family of 4. About 3/4 had heard of EITC, and 65% had heard of the Child Tax Credit. 77% reported that it was hard to stick with a spending plan, and many felt stress about their finances overall. The sample had low financial literacy. 2/3 felt that the clinic should provide these services, and in response to an open-ended question, many felt that job training, financial education workshops, resume building, and computer space would be most helpful. Some key themes found in the qualitative interviews are shown here. And they include difficulty managing financial stress and a sense of hopelessness in escaping the cycle of poverty. Clinic-based support services were highly acceptable for the convenience it offered and the established trust.
Can I ask a quick question? So I'm going to push for us to use the biocontainment unit as our next top-off.
I'm going to mute you all one more time.
The reason is it's, we would have to pulse.
Okay, I think I did it. There's a push for the biocontainment unit. And then the last theme was that families said that they preferred one-on-one employment and financial counseling and group workshops like building a resume. And then this one of the quotes from the surveys, from the interviews is shown here, and it was a female who was age 55. This was the title of our article, "In the Clinic, They Know Us." So this person said, when you go to the doctor, they ask you all of these questions so they know what you're going through. They become your advocates. I mean, some people don't want to speak up, but when they're having issues with jobs and money and all of that, but the doctor could say, hey, I have a client here who needs help, so please talk to them. With grants from the Johns Hopkins Primary Care Consortium and the Urban Health Institute, in partnership with Humanum, which is a Baltimore-based workforce empowerment community-based organization, Dave and Carl and I used data from these two studies to create a program that we called Financial Futures for Families. We recruited undergraduates and graduate students to serve as case managers and work one-on-one with patients and caregivers to help them set and achieve their financial goals. Sorry about that. We also conducted some workshops, and later, given the clear synergy and mission, with Kristen Topel leading the effort, we integrated this program with health leads. Case managers are now called employment specialists and health leads, as some of the students know, and this quickly became the highest need for our patients and caregivers, that is employment. In the past few years, our group has worked with pediatrics faculty at a few other academic centers to share this model through national workshops. Recently, Orly Bell, who was a medical student at UCLA, led our group on a paper describing the concept of what we call medical financial partnerships. Orly's mentor is Adam Schickendance, who started an MFP also as a resident at UCSF before moving to UCLA to join the faculty. In this paper, we describe the model at Hopkins, UCSF, and Boston Medical Center. We define MFPs as collaborations between clinics, hospitals, or health systems, and financial service organizations to improve patients' financial well-being and health as a health intervention. We wrote about the health wealth intervention research that's mostly found in the social sciences literature, which shows that individuals without savings are more likely to have obesity, to smoke, to have diabetes, hypertension, and more. We pose that financial services hold great potential to improve health outcomes. This could be free tax prep, like access to EITC, financial coaching, match savings accounts, and employment assistance. In this figure in the paper, we showed the three different models. You can see model 1 at the top. This is our on-site full scope of services like our health leads or financial futures model. Model 2 just below it shows on-site targeted services like free tax prep. Some of you may know that the program that Lucy Marcil and Mike Hull started in Boston Medical Center called Street Cred. The last model on the right shows where a clinic works in close partnership with an off-site financial services provider, and this is what Adam did at UCSF. In the past year, Adam established a relationship with Prosperity Now, which is a financial security nonprofit based in Washington, D.C., and they've been working with us to create a learning collaborative on MFPs across the country. As some of you know, over the past year, the Health Leads National Program has taken on a new strategic direction. They've moved away from operating resource desks in clinics, and now they do more professional development and technical assistance for community agencies. So just over a year ago, with Kristen's leadership, we began transitioning our Health Leads program, and after input from key stakeholders, including our student advocates, clinical staff, and most importantly, our patients and families, we changed the name to Hopkins Community Connection. Our Health Leads program leaders, Kristen, Sarah, Nick, and Ashley, all transitioned to become Hopkins School of Medicine employees in our division, and we've maintained and actually grown our program in so many great ways that I'll share with you now. I work closely with Kristen on Harriet Lane Clinic operations and overseeing the whole program. Sarah Polk serves as the Children's Medical Practice Hopkins Community Connection Physician Champion, and Mike Fingerhood serves as the Physician Champion at the Comprehensive Care Practice, which is our third desk over at the Bayview campus. Our mission is to catalyze the healthcare system by connecting patients with the basic resources they need to be healthy, and in doing so, build leaders with the conviction and ability to champion quality care for all patients. Goals include continuing our work to build an STOH program that can be replicated through Hopkins and beyond, continuing to meet patient needs in the 3 participating clinics, and provide meaningful volunteer experience in a clinical setting to Hopkins undergraduate students. I do have to mention Ann Langley, who recently left Hopkins for a position at the University of Maryland. Since its inception, Ann, who served as Senior Director of Health Planning and Community Engagement here at Hopkins, has been our key leader in the Johns Hopkins Health System to advocate for financial support for health leads and now for Hopkins Community Connection. Between the 3 practices each year, about 2,500 to 3,000 patients and families are served in the 3 clinics. This figure shows the types and numbers of needs identified between September 2018 and August 2019 for our 2 pediatric clinics, the Harriet Lane Clinic and Children's Medical Practice. We can also see here there are some differences in type of need between Harriet Lane and Bayview. The top needs in Harriet Lane include health insurance, employment, housing, transportation, and commodities like diapers and clothing. And at CMP, top needs are food stamps, help with getting birth certificates, IDs and passports, and enrolling in English classes and dental care. This slide highlights the impact the program is making on our students. Here are quotes from 3 students. The first says, "The program redefined for me what it means to help another person, about accountability to the work as well as to other people, as well as our professionalism. As an advocate, I have been given the opportunity to learn from individuals in the medical and social policy fields, as well as from clients we have been fortunate to serve. I'm working hard to one day become a good physician, and without health leads, or now HCC, I do not think I would ever truly understood what being a good physician or good doctor entails." The second student said, "Simply, the program changed the course of my life." And the third said, "By far the most transformative experience of my time at Hopkins." You can see Kristen at the top picture here in the blue health leads, hopefully now Hopkins Community Connection sweatshirt, and Sarah, 2 over from her, Sarah, who's our Harriet Lane Clinic program coordinator. And the second figure, you can see Ashley in the yellow sweater, who works at Comprehensive Care Practice, and Nick Machado at the bottom, who works at the Children's Medical Practice. As you can see on the slide, 90% of alumni say the program directly impacted the way they think about healthcare, graduate studies decisions, or guided their career choices. And of note, 76% of HCC alumni are working in healthcare, and 54% of those alum are working specifically with underserved populations. The HCC team is expanded across our clinics to include community health workers. This is Wanda Batten at the Harriet Lane Clinic and Melina Stavro at the Children's Medical Practice, as well as social work interns under the supervision of Latoya Mobley. HCC works in close partnership with Fleur and Jessica, who are CMP social workers, and Isabel, who's the Centro Sol Community Outreach Specialist based at Bayview. Community partners are listed here and include Share Baby, Humanum, Sharp Dressed Man, the Maryland Food Bank, who I'll tell you more about in the next few slides, Maryland Legal Aid, Movable Feast, Green and Healthy Homes, Baltimore City Head Start, and Street Cred. In the final part of my talk, I'll share with you our most recent efforts focused on food insecurity. The U.S. Department of Agriculture defines food insecurity as the limited or uncertain availability of nutritionally adequate and safe foods, or limited or uncertain ability to acquire acceptable foods in socially acceptable ways. In the US, about 11% of individuals report being food insecure at least once in the past year. We know from many studies that poor health outcomes are associated with food insecurity. In pediatrics, these include higher rates of obesity, mental health, and developmental delay. The bottom figure is from a recently published guide from the National Quality Forum that shows disparities across groups of different races and ethnicities. As we can see here, the percent who are food insecure is almost double the national average at 21% in Black non-Hispanic households. The National Quality Forum brought together multi-stakeholder perspectives on key components to overcome food insecurity through healthcare-based interventions. Our own Kristen Topel, HCC program manager, was one of the key contributors to this report. The report highlights promising interventions like medically tailored meals, which were found to reduce ED visits and costs, which was published by Seth Berkowitz from UNC. The report recommends that health systems need to have greater awareness of the importance of food insecurity. They need an organizational culture that embraces the role in addressing social determinants and develop processes to screen, intervene, and track. The report highlights studies that have shown written screeners are superior to verbal screening in primary care, that tablet screening is also better than verbal screening. And when this occurs, clinical action is needed to identify next steps. This includes connecting patients to public programs like SNAP or WIC, referral to food sources, provide food in the clinical setting, and importantly, to address the root causes. Health systems should measure results and unintended consequences, which could occur through the electronic medical record. And to be successful, patients and communities need to be engaged and at the table from the beginning. Food as medicine interventions have emerged as a strategy to prevent or manage chronic conditions and simultaneously address food insecurity, reduce healthcare costs, and improve health outcomes. In this recently published case report from Massachusetts, the food as medicine pyramid shows the different levels of intervention. Medically tailored meals at the top are the most intensive. This requires referral from a healthcare provider or health plan. Meals are designed based on a dietitian's recommendations for a patient's medical diagnosis. Typically, meals are prepared and home delivered. At the next level down, we can see medically tailored foods. And these programs, packages of non-prepared grocery items, again selected by a dietitian and based on a specific medical diagnosis. The patient's usually able to pick up these foods and prepare them at home. At the next level, healthcare providers give patients vouchers or prescriptions for free or discounted produce, again to address specific health conditions, and these vouchers can then be redeemed at grocery stores or farmers markets. Fourth down in the pyramid are the population-level healthy food programs. In these programs, healthcare providers partner with an anti-hunger program to distribute generally healthy food to any patient, regardless of their health status or condition. And at the very bottom are the public health benefits and food assistance programs that the majority of our food insecure families rely on. As you can see on the left and working down, the pyramid interventions go from treatment to prevention. And on the right, we see, except for the foundational SNAP, WIC, and emergency food programs, all four interventions should be considered priorities for healthcare funding. In 2018, Mass Health, the Massachusetts Medicaid program, implemented a program redesign that enrolled members into 17 ACOs. In January 2020, ACOs were eligible to receive funding that can be used to pay for services that respond to health-related social needs, including these food as medicine interventions. The Massachusetts Food as Medicine State Plan is a 2-year statewide initiative aimed to assess current status to food as medicine interventions in Massachusetts and develop recommendations to scale these up across the state. As you can see here in the fourth column in green, sustainable funding occurs when healthcare dollars from private and public insurers are funneled back to reimburse providers for screening and to community-based food assistance programs. In the Massachusetts plan, as shown at the bottom, this will require support from payers, providers, policymakers, and philanthropy. This brings us to our Hopkins program, which could be classified as a population-level healthy food program. We will be providing food to any food insecure patient with emergent needs, regardless of their health status or medical condition. As many of you know, during her residency, Hannah Fuji Rios worked with Jan Serwin, Ann Kane, and Therese Canaris in the pediatric ED to conduct a pilot project screening for food security in the ED and provide food. Hannah led a very successful project and initiated a partnership with the Maryland Food Bank. Last summer, just before Hannah graduated, we began transitioning this program to our Hopkins Community Connection team. Our team is large and includes our Maryland Food Bank partners. At the bottom, you can see here, those are Meg Kimmel, Kate Long, Rick Condon, Jessica Cornelius, and Zanika G. Our Johns Hopkins team is also large and includes Hannah from Afar, Lauren Burgunder, Brittany Hunter, and Gila Sella from the residency program, Janet Serwin, Kristen Topel, Sarah Hill, Ben Wormser, one of our undergraduates, Hannah Chu, and our dietitian, Laura Davis. Recently, Jamie Margolis, Tracy Carter, and Toya Mobley, and other Harriet Lane staff have joined the team as well. Our plan is to screen for food insecurity using the Hunger Vital Sign developed in 2010 by Children's Health Watch. A positive screen results in a referral to HCC. The advocate then will ask whether families have enough food to last for the next few days, and if not, they'll receive 2 emergency bags of prepackaged food, 2 meals and 2 snacks for a family of 4. Like every HCC client, the advocates will assess and link the family to benefits if they're not already enrolled, like food stamps, WIC, and temporary cash assistance. And importantly, they'll screen and try to address other root causes like employment and education needs, and then they'll follow up with them weekly. Here's our new HCC social needs screening tool. As you can see, in addition to food, we screen for housing, jobs, childcare, transportation, utilities, finances, legal assistance, commodities like diapers and formula, help with resume building, and more, shown here on the right. We also ask if any of these needs are urgent. This recent revamping of our screening tool was led by some of our HCC student advocates with oversight by the program leaders. Our redesign also included piloting the new tool with patients and families. Many of the new screening tools are validated and embedded in EPIC. The 2-item Hunger Vital Sign now shown here are shown, and often true to at least one of these 2 is considered a positive screen. So here's the big news. Just last week, we launched our new HCC food program. Yes, you can see here, this is the Uta Wood room in Rubenstein. And if you look closely, you might see paper bags spread around the table, 6 feet socially distanced apart. Next, we can see Sarah Hill welcoming the 2,000 pounds of food from the Maryland Food Bank truck right in front of the Rubenstein building. And then Jamie and Sarah are seen here in the front, getting ready to unpack the boxes. Tracy Carter is helping Sarah move things into the new food pantry, which is actually Kristen Topel's office. And finally, the display of all of the bags ready to be distributed. In just the first week, we provided food to 22 Rubenstein building staff and 25 families in Harriet Lane. 10 bags were given to the children's medical practice to start them off. And for the past few weeks, Kristen and I have been working with Nikki McCann, Sharita Golden, who's the Chief Diversity Officer for Johns Hopkins Medicine, her team, and Panagis Galiastos at Bayview to scale up the program during the COVID crisis to help Johns Hopkins Hospital and Johns Hopkins Bayview Medical Center employees who are experiencing food insecurity. We've identified sites on both campuses, and we're now developing the workflow. Our plan is to purchase food from the food bank, which the next shipment is to arrive this Friday, and start providing food for 100 staff on each campus in the coming weeks. This is an incredible team dedicated to supporting individuals who we work with every day, many of whom may be struggling silently to access food for their families. So to summarize where we've been, if you're not already a believer, I hope you can now appreciate that now more than ever, social determinants are part of our pediatric scope of practice, and really our practice in all of healthcare, and must be seen as a professional responsibility to improve the health and well-being of our patients and families. While there is some evidence to support SDOH interventions, like those related to social needs screening and referral, and interventions addressing food insecurity, more research is needed to move the needle to reduce child health disparities and health disparities overall. And finally, this work cannot take place without strong community partnerships. With our partners, academic medical centers are well positioned to develop, test, and scale innovative models to address SDOH. I need to acknowledge the funders of our Hopkins Community Connection program. As I mentioned before, we're grateful to the Johns Hopkins Health System for continued support of the program. Jan Rivets and the Strauss Foundation is helping us during this bridge period to transition from health leads to the Hopkins Community Connection program. Through Redonda Miller's leadership, the Weinberg Foundation recently provided support, and we also received funding from President Daniels' office. Also, a big thanks goes out to Alicia Cleaver and her team. They helped us apply for and secure funds from Morgan Stanley and Rite Aid, and Alicia continues to be a big champion for this program. And then before I take some final questions, for the Hopkins initiatives, I want to thank many people who have helped and continue to lead our efforts in pediatrics to address social determinants. Of course, this includes HCC leaders and our undergraduate student advocates, social work interns, and community health workers. They're the ones on the ground in our clinics and now working remotely, helping families every day. Also, big thanks to our social workers, mental health providers, and case managers who work tirelessly to address our patients' social and emotional needs. Our dietitian continues to be helpful for the new food program. Our front desk staff, nurses, nurse leaders, and CMAs, residents, fellows, faculty, and nurse practitioners are the critical link who develop trusting relationships with patients and families and compassionately respond to positive screens and really open the door to discussing these sensitive issues. And finally, our ambulatory medical directors, Megan, Sarah, Julia, Nicole, and Erica. Rachel Thornton for taking the lead with the HCC on organizing resources during this crisis, and our institutional, children's center, and clinic administration leaders like Redonda, Letitia, Tina, Maggie, Alicia, Phil, Chuck, and Mark, who understand our professional responsibility and continue to serve as strong advocates. Thank you very much, and I'm happy to take any questions by chat or by voice.
If anybody has any questions, please feel free to either type them in or unmute yourself.
Yeah, if you want to unmute yourself and ask a question, that's fine too. I also understand it's getting close to 1:15, but. Sure. Oh, Tina. Can people hear me? So Tina asked, how can we expand this to the inpatient service? And I think we should. I think we need some champions on the inpatient side. I imagine that Kristen and Toya and everybody else can really think about who those individuals might be. I'm sure Paula could really help with that as well. So I'd be happy to assist as well. I think in the entire screening for social determinants and then specifically for food insecurity, we've already started to do that. Actually, Kristen is working with the PICU in adding a food order for them to this Friday's shipment. And it looks like there's a question, I can't see who it's from, but it says, yeah, how do we ensure a patient who is inpatient or specialty with urgent housing needs, for example, get actively involved in the HCC program? So here's great news right off the press that Hopkins Community Connection has an email, and it's pretty easy. It's hcc@jhmi.edu. So hcc@jhmi.edu. Hopefully Kristen and Sarah and all the program leaders don't kill me for sending that out, but that is in the community resource document. And I think now more than ever, as I said, and as Tina mentioned, thanks Keith, that we do need to be referring. We have advocates who are all working remotely and they're very eager to help. We also have other students and medical students that Sarah Polk's been working with on the Bayview campus, and some of us are working with on the East Baltimore campus, who have been helping with looking at the resources for specific patient populations. So just send them an email and hopefully they can connect you with resources.